But honestly, what brings people in to get help, whether it's inpatient or outpatient, is like there's a functional problem.
Right.
Like, there's a legitimate problem happening. Like, how can we get this better? And I think we have to be careful, because when we start going down the path of all these different diagnoses, like, do we lose track of what the actual problem is?
Yeah.
And that makes the job harder, not just for a clinician, parent, the person that's dealing with the problem, because it's like a mirage. It's like, let's put up a bunch of mirrors and then be like, this diagnosis, this diagnosis, this diagnosis. But then I'm like, well, wait a minute. Let me go back. What was the actual problem?
Yeah.
Oh, yeah. Okay, that was the actual problem.
Welcome to the Little Brain Campaign. I'm Dr. Lauren LaRose, a child and adolescent psychiatrist.
And I'm Jessica Eisenstadt, a licensed professional counselor.
We're here to be straight with you about children's mental health.
And we're not afraid to challenge the trends that are out there about anything related to kids.
And we're not afraid to challenge each other either.
If you're looking to be validated from two moms that are in the trenches, you're in the right spot.
Yep, no fluff here. Just some honest conversation with a side of sarcasm.
Let's get into it. Hello, big brains. Thanks for joining us. We are your hosts. I'm Jessica.
And Lauren.
And today we have the pleasure of talking, consulting, and hearing all about the experiences of Dr. Ashifur Rahman. He is a child and adolescent psychiatrist here in New Orleans.
So Ash and I have known each other since residency, since medical school, actually.
Correct.
A long time. Did medical school together, residency, fellowship, and he has worked in a lot of different settings: inpatient psychiatric hospital, outpatient clinic, some emergency room consultations, medical hospital consultations, all kinds of things.
A lot of stuff.
Lots of stuff. Okay, so I think we'll probably pick your brain to start about your inpatient experience, because that's very different from what we do.
Yeah, but I want to talk about the contagion.
Oh, yeah, we're going to talk about that.
Okay, can we do that first?
Yeah, we can talk about that first.
Okay.
The contagion.
Okay.
Okay, define it.
So, in medical terms, contagion has always been talked about with like diseases, like infections and things
like contagious.
Like that. Yeah.
Okay.
Like something is contagious, but then there's the principle of everything spreading, and that's contagion.
Like the movie.
Yeah. But it's become much more of an interesting topic in terms of psychiatry.
Okay.
Because I think probably the dynamics of like social media, a lot of the changes that are happening with the awareness of mental health.
Yeah.
It's become much more in the forefront. And in the scope of what I see, I've seen a lot of that change in regards to like the inpatient psychiatric stay.
Okay.
When we think about it in that terms, it's more like emotional contagion.
Okay.
'Cause you got to think about inpatient psychiatry. Someone's being brought to the hospital for help, sometimes voluntarily, sometimes involuntarily. They're put in a unit for whatever reason. It could be for suicidal thoughts or homicidal thoughts or overdoses, things like that. And they're a lot of big emotional states then.
Yeah,
and they put in,
like in crisis.
Yeah, you're in crisis.
Yeah.
And then you get put into the hospital, and then you're around a lot of other people that are in crisis.
Yeah.
And the other thing, too, is you're kind of taken out of your normal life. You're not at home. You're away from your family.
Right.
You're not around your support network. And then all of a sudden, you kind of have to build this support network because you're like a stranger in a new area, and then you're around a bunch of other strangers.
Yeah.
And so then
It's kind of like jail.
Kind of like jail.
I mean, a little bit.
A little bit like
You know?
jail.
But
Nicer.
you gotta, I mean, not that I know. But
Food might be
right.
about the same.
Temperature controlled. Yeah.
Comparable.
Yeah.
But you get put into this like really emotional place. A lot of people going through crises. And then you get this idea of like emotional contagion. So you're feeding off everyone else's energy. You're exposing your own energy, whether it's in groups or talking to other peers. And so that's been a hot topic, I think, in psychiatry, more so in the inpatient. And then we've kind of seen it in like school settings too.
Tell me about that.
Well, I mean, I think in school settings, with mental health being much more at the forefront, people talking about it more, the dialogue's opened up a lot more about it. And so in that, people are being much more aware in school settings. Counselors are talking about it, teachers are talking about it, and the biggest thing is students are talking about it.
And what, like, how do you know something is I'm not saying this in the right, Contagion, or is a Contagion?
Well, I will say from experience, we've had situations on the inpatient unit where we've had a lot of like students from like a same school that would be coming, and
my God.
you know, whether that's they have similar problems, or they're like, you know, whether they're both struggling with like depression or anxiety. But in the context of probably what I see more is like they may be going through similar psychosocial stressors at home or in life, or bullying and things like that.
For the non-mental health people, what is an example of a psychosocial stressor?
It could be friend problems,
Okay.
parent problems, family problems. It could be also like food insecurity.
Yeah.
It could be financial issues. It could be all those life stressors
Yeah.
that really are not more psychologically based, like internal or biologically based, like psychosis or bipolar, things like that.
Okay.
So a lot of them have like similar problems, and they're all struggling with it. And so sometimes we see contagion in that they're coming to the hospital together because they're all wanting to kind of want to break away from all the problems that are happening in their life. And so they come to the hospital. They want to be with people that are also going through the same problems. A lot of times it can be peers in the same school system, and it starts kind of trickling down where then, you know, people find out that other people are in the hospital, and they're like, well, I want to go to the hospital. I want to go to the hospital. And then there's this idea too that like it's a little bit glamorized.
Yeah. It's kind of like sexy.
Yeah,
Yeah.
it's like, well, I've been in the
Trendy.
hospital. I get to be away from all this.
Yeah.
And then you know, from their perspective, it's like we've taken them out of their like really stressful life.
Yeah.
And we've given them a break a
Correct.
little bit.
Yeah.
And that can sometimes be talked about in these circles. And then, well, they're like, well, I'm really having a hard time. I want a break too.
Yeah. Totally.
So then starts becoming a little bit contagious, and there's this idea that the hospital really represents like a break from
Yeah.
life.
I mean, a little bit. It is though. Like it's safe, secure, predictable, kind of.
You're removed from outside stressors of life.
Yeah.
Correct,
Right?
correct.
Yeah.
What about like contagion that happens on the inpatient unit? Is that something you see?
Yes, definitely. I've seen it with like certain diagnosis.
Ooh, which ones?
Well, tic disorders was really, really interesting.
the one
Well, I know.
I
She
said
did say,
earlier.
what do you mean?
And I don't
Like,
know,
what do you
there was this like very viral video
Oh.
of like students in a classroom in New York City, and like, you know, it was like a couple of students that were having, you know, various symptoms of like a tic disorder, and then all of a sudden like the whole class was having.
What's the tick? Like, what would the tick be?
It could be like involuntary movements, or like vocal tics, or like they're just like clearing their throat, or they're saying certain words. It could be all these different things. And then it was like a bunch of people in the class started doing it.
Yeah.
And so I've seen that on the unit where someone comes in, someone has a tic disorder, thinks they have a tic disorder, and all of a sudden it's like, you know, 2
Put
days
your mic.
later, then like 2 days later, like there's like 5 people, and they're all having tic disorders, or they're asking about tic disorder, or they're like, I think I have a tic disorder.
How do they even get an inpatient? At like, you know what I mean? To like, even try to convince someone they have a tic disorder.
They usually will come in for other things.
Okay.
And then within the realm of like the assessment and finding out what's going on, they might say like, I have always struggled with tics, and then they'll talk about it with someone else, and then all of a sudden it's like,
We all have
it's
tics.
like we all have tics.
Okay.
So do you see this tend to happen more in certain age groups versus others?
Yeah, I think the younger,
Interesting.
because I think a lot of units are divided among ages. So
Oh, I didn't know. Yeah, talk to us about, because I don't know how, like what child and adolescent psychiatric unit, whatever, even looks like.
Well, I think every one of them is kind of different.
Okay.
Some can look very institutional. Some can not look very institutional and just look like regular buildings.
Right.
But I know a lot of units probably more so divided up by age.
Okay.
And so probably the thing we're talking about with Contagion is usually with the younger adolescents, maybe like 8 to 13.
like middle school.
Yeah, yeah.
Like eight's third.
Upper, lower school to middle school.
Right? Yeah.
Okay.
Yeah.
Like upper elementary, middle.
Yeah.
Got it.
Yeah. Now it's interesting. The contagion might be different for like the older adolescents,
Right.
Because then it might be more not like a tic disorder, but it's like I am all of a sudden questioning like a diagnosis. Like I have autism, I have bipolar, I have. They don't really say I have psychosis, but you know, they're bipolar and autism. That's usually what it is.
Really, those are like the two
Yeah.
like hot diagnoses right now to like convince yourself, or for a older adolescent or whatever to convince themselves that they are.
I think neurodivergence in general.
Yeah.
You know, and it's because there's a lot on social media about that.
There sure is.
There's tons of TikTok videos.
There's so many TikTok videos.
You know, I think to some extent ADHD, but definitely for a while it was like bipolar. Everyone was like, I think I have
But that's not neurodivergent bipolar. That's a mood disorder.
Yeah.
Like that's not under the umbrella of neurodivergence.
Yeah.
Okay, if I'm 16 and I definitely have bipolar 1. What does that kid look like when they enter the ER? Like, is that what happens?
A kid who actually legitimately.
No.
That's what you're asking. Oh
No.
Okay.
No. Like,
You've convinced yourself. You have
yes. Like because what did you say? It was like the diagnosis contagion? Is that what you said?
Yeah.
So do they just like show up at the ER?
Usually if they're bipolar 1, if they're not stable, they usually come in manic. And then they're like really having symptoms of like
So she's
bipolar.
talking
Yeah,
about
I'm talking about
someone
like someone who has
who doesn't
convinced
have it.
themselves.
Oh.
Like if at this school in grade 11, everybody thinks they have bipolar 1.
Okay.
And so how does that like present, I guess, like in the ER? I don't know if I'm saying this right. Like
Probably
does
not.
it?
Probably
Okay.
not. Now, in the context of maybe they're having like an acute crisis where they're suicidal or they may have attempted in some way, and then when we get them on the unit because of that crisis, they may say, "Oh, I have a history of like bipolar 1."
Oh, and you're like, can I see the eval?
Yeah. And then as we're doing the eval and we're like screening,
Mm-hmm.
they may be like, "Well, I really think I have bipolar 1, and this is why, because this."
Like here's
and then
the
summertime,
DSM-5.
it's like, "Here's DSM-5."
Yeah.
And I was like, "Oh,
That is the
that's great.
diagnostic statistic manual. I'm not right.
Yes.
The revised.
They
'cause
can
now
like
there's a revised.
spew out the criteria
Right,
Yeah.
to
right,
you.
right.
Yeah.
And it's interesting, but also it's a little bit of a refresher for me because I'm like, oh, okay,
Yeah.
well, diagnosis of
Here's some.
DSM-5,
Here's the
that's great.
CEU. Why do you think? Like, what is the like not point of contagion? But like, what is the like? Why do you think kids are potentially wanting like a diagnostic label?
Why does this happen?
Well, you gotta think like a lot of kids, adolescents, teens their age. I mean, it's identity formation right now.
Yeah.
They're trying to figure out who they are.
Yeah,
They're trying to figure out who they are.
in relation to others.
And and honestly, in relation to the world.
Yeah,
like,
that's
how do
true.
I fit into the world?
Yeah.
What am I going to be? What is life going to throw me? What am I going to get out of life?
Right.
So that plays a part in it. Honestly, also, just a lot of patients that we see in inpatient unit, they feel alone. Whether it's like their family didn't know about the struggles they had, or they didn't feel comfortable opening up with it, about the struggles they had. So they come on a unit, and all of a sudden they get a very supportive. It's like other people are going through this.
Someone cares.
And so, that could be a reason because now they finally found like support. Like I'm not alone.
Yeah.
And then with that, it makes them open up the idea like, am I suffering with other things?
Right.
Because that person has the same problems as me, but they're also suffering with this. Like,
Yeah.
Well, and you think about it, like if you decide one day that your identity is neurodivergent, at least that's some identity versus not
better
having
than not.
one at all.
Yeah,
right?
correct. Yeah.
So it's like they're kind of like clinging to something, and then if they have that something, then they have a reason to connect to other people who are also neurodivergent, right? It gives them like
A sense of community.
community.
But ain't that some shit? Like when I was growing up, or all of us, I mean, like mental health, like no one wanted, like it was like a label. It was taboo. It was like,
I don't even think we even said mental health, right?
no,
That
but
was not
like
even
a diagnosis, like
Yeah.
I don't even, maybe ADHD was kind of, I don't know, but you didn't want that, you know?
Right.
And like now, which one am I today? You
Yeah.
know?
Yeah.
That's just so interesting.
Yeah.
Which lends me into so do you know what PDA stands for a lot of different things, but in regards to symptomology or diagnosis, do you know what PDA? Have you heard of PDA?
I've heard of it. Yeah.
Do you know what it is?
It's
Keep it going. You trust yourself, son. You do it. You had the right word.
Let me hear from y'all on what y'all think about PDA.
Well, do you know what it stands for?
I've heard of it,
Yeah.
but I'm not 100% sure of that.
Okay, pathological demand avoidance.
When she
Okay.
first said it to me, I was like,
I've heard the
public displays of
pathological
affection? I don't know.
So
demand avoidance is new to me. Yeah.
Okay. So it is like, this is kind of, I guess this is
It's the
contagion.
newest TikTok diagnosis.
Okay.
I don't know if it's not in the DSM obviously,
Yeah.
but it's like a symptom that people, parents, professionals are connecting to like autism spectrum disorder,
Okay.
ADHD. So, from my understanding, it's just like a high level of defiance and maybe like a really intense reaction to authority, right? And so now there's this thing called PDA, and people are using it to label a behavior, but no, like it's not even a real
It's not
diagnosis.
a recognized diagnosis.
Yeah, and so
Or medically recognized, I should say that.
right, I don't know, and so it got me. We were talking and thinking. It's almost like people are looking for an excuse or a reason behind an undesired behavior, right? Whether it's in themselves or it's my kid, it's my whatever. Like, oh, it's not because of the way I'm acting, or it's not a reflection of like the way I parent or teach or whatever. It's them because they have this, right?
Right.
Yeah.
Right.
Yeah.
It's something to point to like give an explanation for something that like you don't understand why it's happening, right? Or you're feeling frustrated that it's happening. And when you give a label to it or an explanation, I think that, I don't want to say like lets you off the hook, but like
You don't have to be responsible though.
right. It kind of removes some responsibility. So yeah, I think it's just like an example of like how these social media platforms are, in some ways, like increasing awareness is great. Like increasing awareness about mental health, decreasing stigma, in some ways that's great. In some ways it's like, are we way over pathologizing things?
Well, and then I think the New York Times just came out with an article about that too.
Tell us.
Oh my
where
gosh,
it
we
was
should have
like, did
written
we
it.
go too far the other way?
Yeah.
Yes, we did.
And with talking about mental health
And
what are the
parenting.
boundaries in that? you
Yeah.
know?
Right.
Now back to like when we talk about diagnosis, like
Yeah.
PDA. I agree with Lauren. It's like, as a child psychiatrist, I think one of the biggest things is like there's lots of different diagnoses. DSM-5 is
Right.
this crazy huge book.
Yeah,
it
and the
has, like, all
revision,
these-
they just
yeah.
came out with the revision in 2022, but keep going.
But honestly, what brings people in to get help, whether it's inpatient or outpatient, is like there's a functional problem.
Right.
Like, there's a legitimate problem happening.
Mm-hmm.
Like, how can we get this better? And I think we have to be careful, because when we start going down the path of all these different diagnoses, like, do we lose track of what the actual problem is?
Yeah.
And that makes the job harder, not just for a clinician, parent, the person that's dealing with
Yeah.
the problem, because it's like a mirage. It's like,
Yeah.
let's put up a bunch of mirrors and then be like, this diagnosis, this diagnosis, this
Yeah.
diagnosis. But then I'm like, well, wait a minute. Let me go back. What was the
why are
actual
you here?
problem?
Yeah.
Oh, yeah. Okay, that was the actual problem.
Right.
Yeah.
Right.
Yeah.
Because you can have ADHD and it's not affecting your day-to-day functioning
Correct.
at that time, right? So it's not just because you have this diagnosis that you have this problem.
And we're still a results-driven society. So
Yeah.
whoever's coming in and for whatever reason, they want results. Like, I want to feel better. And what is
Yeah.
the tangible goal of getting better? That hasn't changed. In every other part of our world, it's still results driven. Like sports, money, finance, all
Yeah.
these things. Yeah.
And you have, clinicians have to, if they want to get reimbursed by insurance, you have to have a diagnosis.
Yep.
Yeah.
And that diagnosis has to fall under whatever I don't know how, like if I coded like I don't even know if it's called that anymore, like not otherwise specified beep bop bop, that they probably wouldn't reimburse because that's not something that is like clinically significant and is
Yeah.
So like now it's like, okay, well,
Now you have to diagnose.
now you got to diagnose.
Even
And
when
like
maybe
I
there isn't
I do everything in my power not to. I'm like,
Yeah.
please hope they have an eval coming into my office already.
Yeah.
And I only take one form of insurance too. But that's just another,
Yeah. It's like you end up having to put a label
Yeah.
on it. Okay, so something I want to ask you, because you finished training not that long before COVID, right?
Yeah.
Okay. Tell us, like, have you seen trends since COVID? If so, what are they in terms of like diagnoses, reasons for referral sources, reasons for admissions to inpatient unit?
I think I've definitely seen the rate of depression and anxiety go up. Yeah, that's definitely multifactorial, but
Is it like a certain age group attached to
I
that?
think across all.
Like,
I've seen probably a lot more earlier diagnosis of like depression or anxiety or, I mean, honestly, major depressive disorder.
yeah. What's the earliest, youngest?
I mean, we've seen, the unit I work at, we have 7-year-olds, and there's some that have come in with that diagnosis.
And what does it look like? What does MDD look like on a 7-year-old?
Now, you see, the question is like, it's hard to tell if that's really MDD on a 7-year-old.
yeah,
because,
right.
when we did training and, our fellowship, it's like, that's just not the normal timeline of what you would see.
Yeah,
Like neurochemically speaking.
Yeah.
Yeah, like major
are you even
depressive disorder.
capable? Like, is the brain
Capable
even
of having
capable?
major
Even?
depression.
Yeah, correct.
Yeah.
But, you see the diagnosis start popping up at earlier ages. I think another trend has been just the dependence on social media.
Yeah.
And
God,
that's a
here we
pandemic.
go.
It's like,
Let's go.
so here's the thing, back to what we're saying about some of the contagion being related to connectedness, trying to connect with people. I have to tell parents, I had to tell a lot of parents during COVID, I was like, you guys forget like where your child was the majority of the day. They were in school.
Yeah.
They weren't at home. They were at school. They slept most of the time when they were at home.
Yeah.
But between school and extracurricular activities, they spent the majority of the day away from you around their peers.
Yeah.
And all of a sudden you have a pandemic and you've kind of taken everything away from a very vulnerable,
impressionable.
group.
Yeah.
And now you're like at home, and sometimes that's good. That was like nice for some because it was like, ooh, I was always anxious in school. Now I don't have to go to school.
Yeah.
It's great. But then we had another that was like, I thrived in school. I
Yeah.
loved being social. It was nice to be away from home because of things that were going on at home. Or
like, the lights are on at school.
Yeah.
Like I
Yeah.
get fed at
Absolutely.
school.
Or just because developmentally in middle school and high school, you are supposed to be with peers more than with your parents.
Correct. And then that was taken away. And then all of a sudden it's like, well, how do I connect with anyone?
Or how do I even learn?
How do I learn? How do I figure out what's going on in the world?
Yeah.
Because we're stuck inside. We
Yeah.
can't really go anywhere. There's just constant fear about
Yeah.
people getting sick
And dying.
And legitimately that was happening to some of the kids and teenagers. Their family members died.
Yep.
And so they went to what they were comfortable with.
Yeah.
And that was social media.
Yeah.
And they're like, oh, this is at least I'm feeling something.
Yeah.
I'm connecting with someone.
Yeah.
Whether that was like good or bad and what they were seeing, those are all like different topics that are could be a whole
we'll be back.
Yeah. But they saw what they saw.
Yeah.
And then what ended up happening was for some it was like, okay, that's fine. I'm doing social media. But then we started seeing a trend of like a lot of the stressful things that were happening in their lives, they weren't able to handle it because you can't escape it. You can't go to school. You can't get away from it.
Yeah.
So they were coming to the hospital.
Yeah.
And what would that, like, what would they come to the hospital?
They would come and, it was like they would say I was suicidal. And then all of a sudden during the pandemic, like usually I remember that first few months of the pandemic was the summer. And usually in inpatient psychiatry, we get like a lull. You usually don't.
In summer.
Don't
'cause
see as many
kids
patients.
aren't in school.
Yeah, it's like
no one's reporting.
Yeah,
No
it's like there's
stressors.
less
Yeah.
bullying, no school. You know, I'm having fun. I'm going to camps and doing all these things. That first summer of the pandemic, we were full.
Crazy.
Yeah.
We were full. We actually at one point, I think we had more people in psychiatric hospital than we did like the main hospital.
Wow.
That's insane.
Have y'all like consistently stayed full since then?
No,
Oh.
That's
okay.
good.
no.
Okay.
Okay. That's comforting.
I think the first that first summer was really busy. That second summer was still busier than
Yeah.
normal, but I think now we were like
tapered.
trending back towards what we
Yeah.
were seeing before the pandemic. But I was seeing so many people coming in, and it was really honest. Some of the teenagers were really honest. Like, I just need to get away.
Yeah.
Like, I just need, and it was like, sometimes it was hard to manage the milieu. We were understaffed.
Yeah.
There weren't doctors. People were doing tele at that time because some of the doctors, like, I need to be safe for my own family. And they were just enjoying themselves on the unit because it was like, oh, I get to be around people. I get to be around, and like, I just want to be around other peers. Is that like, and make some social connections. And it made it, we ended up seeing a lot of kids come in because of that. And then it was making discharges really hard too.
Yeah.
Because there were a lot of sabotaging discharge because I don't want to go back to what I was. I don't want to be isolated from everyone.
Yeah.
I don't want to be like back in my bedroom for the majority of the day, just dead scrolling or looking at different things.
Yeah.
I actually want to be around other people.
Yeah.
And
That's how we're meant to be.
Yeah.
Yeah. Going back to the early diagnosis of major depressive disorder in a 7-year-old. And the original question was what does that look like? And it sounds like it's, it may be atypical symptomology or like symptoms that are presenting more like an ADHD diagnosis. But so how do you figure that out? You know what I mean?
I think you're getting a really good timeline too. Usually what I've seen with younger kids that have really had like true major depressive disorder, like they have like a really strong family history of depression that may be playing a factor. But unfortunately for what we do in child psychiatry just in general, we see a lot of trauma.
Yeah.
And so we'll get like really, really tough trauma cases at a young age. And because of
the trauma,
they're having like depression, and things like that.
Well, and I think like one question is like, is it really the same as like major depression in an adolescent and an adult, or is it a different process that's going on, but it's just presenting in similar ways?
I think it could be different too, because with the really little kids, like they don't have this huge emotional vocabulary where they're going to be talking about this is what depression feels like.
No.
For me, this is sadness, this is anhedonia, all these like really big terms. It might just come out in like externalizing behavior.
Yeah, they're hitting,
they're
throwing,
taking out their internal feelings on other people, themselves, they're not sleeping. And that could present like some other things, but it usually would present differently. And then it just didn't make sense. It's like, well, this doesn't feel like this traditional ADHD or something else. Like we're missing something. And then as we explore it more, and work with them, it'll be like, oh, maybe this is really like depression. You know? And it's not, it's like surprising because it's so young, but this is depression.
Yeah. Okay. What about mood? I'm interested. Are you seeing any, I don't know, or like what are the rates of like mood disorders presenting like in the ER, or like the
true mood disorder?
True,
like
in kids. Yeah. Like, do you see it?
We see it.
So, like, the reason I say this is because I worked in a school setting for a number of years, and with kids with IEPs, exceptionalities, all that stuff. Most of the time, OHI, ADHD. Then you have autism spectrum disorder. Randomly, you would have ED, emotional disturbance, and then I think there was one kid who was in 2nd, 3rd grade, diagnosed with bipolar. And so now he's on all the heavy hitter medications. Anyways, and so like, are you seeing that? And like, what age, rates?
Honestly, we probably see true like bipolar disorder in older adolescents.
Yeah.
Now, when we see them coming in with a diagnosis at like at that young of an age, I think that's when we like really got to put our like diagnostic hat on and be like,
Yeah.
why is this like, and because like, we're curious.
Yeah.
It's like, well, how did they get this diagnosis?
Yeah.
You know,
I'm an idiot. No, I'm just kidding.
and then the second thing is like you said, like the medicines, they work, but they're strong.
They're heavy.
And they what do
got
they do?
Legitimate side effects.
Yeah. What? Because I didn't know this. Risperidone. What's
Like
the?
antipsychotic medications.
Yeah. What did you say? Like it increases the chance or
Metabolic
rates
syndrome.
or
Is that what you're talking about?
diabetes?
Yeah. That's
Like,
part
I
of
didn't know
metabolic
that.
syndrome. Yeah.
No, I don't know.
Yeah. So
I'm
those
not a
medications
doctor.
are heavy. Like they carry a lot of potential long-term side effects.
Yeah.
So you don't prescribe
Diagnose
them
it
like
lightly,
with a grain of salt. It's like you got to be sure that kid needs that medicine if you're going to put a kid that age on it. You know.
Yeah.
So, which I think, unfortunately, some prescribers may not like appreciate the risk, like how significant that risk is, because they are, the medicines are potent, they're strong, they're going to do something, they're probably going to dampen some kind of behavior, but is that really what's needed? So like when you were talking about bipolar disorder, there's like a lot of what's the word? Not controversy. Yeah, a lot of controversy about like that diagnosis in kids as opposed to adolescents. There's a lot of disagreement among psychiatrists. Like so child psychiatrists are not all on the same page about whether children, like,
what is that age though? Give me like that age.
So children
range.
is like under 13, right?
Okay.
So if you talk about children versus adolescents, children are like under 13, adolescence is 13
14.
to 18 or 13 to 19 really. Okay. So there's a lot of like disagreement among psychiatrists about whether or not children under 13 can have bipolar disorder, like if that's chemically possible. Okay. So there are some psychiatrists who say, yes, it is possible. And then there are some who say, no, it does not happen until adolescence. Ash and I were trained in the same place. So our training was that, no, that is an adolescent and an adult disorder, and that does not happen in children.
Hold up.
Yeah. So.
No, wait, I have a question.
Yeah.
Okay. So like, I hope I'm not like dumbing down my profession. So counseling, right? Mental health, counseling, social workers. It's very theory based, like you kind of choose which theory, which modality, feels most natural, whatever, all of that stuff. We have more, I guess, autonomy. Yeah. I don't know, as it relates to treatment modalities, right? Doctors, I didn't know, like, I guess I thought it was more like this, you learn this and this is what you do and this is why.
So I would say in most medical professions, yes, but ours is an exception. Psychiatry is a huge exception because you think about it, like up until now, I mean, we're starting to get more like data-driven ways of diagnosing things, but forever until now, there's no like blood test to say if you have bipolar disorder, or there's no like, there's the CT scan. Well, now we have that thing. Yeah, we'll talk about that later. But so we're able to disagree on it. Like we're able to, you kind of can have an opinion about whether or not it exists in kids.
And it's like and this goes beyond, but like, what region of America are you in? Like, what ethnicity are you? What's your family culture? What behaviors are like, you know what I mean? Like normed. And
you have to say like, we may see the symptoms might be the same. We might be seeing the same symptoms that like someone in Chicago is calling bipolar disorder, but we're calling it trauma, right?
And also bipolar is such a big range of symptoms.
Yeah,
there's like a gradient. We also have like, there's like selector bias. It's like where we trained versus where someone else trained versus.
Are y'all not trained the same way?
No.
What?
Versus the community they are in might be different. And so someone that I think might have bipolar, someone else might not, and and so that plays
subjective.
Because we don't have lab values. It's not like we don't have a hemoglobin A1C to track someone with diabetes, or we don't have blood pressure like with someone with hypertension.
It's not black and white.
It's not, and so it really
depends.
It depends.
I hate that.
Well, We are running out of time. I wish we're
Well, you're gonna be
you're
back.
gonna come back.
Yeah, because like
We
we
need more
haven't.
time.
Yeah,
We need more time.
you'll be a monthly.
But thank you, Ash.
I know.
Yeah,
Thank you for
thanks for having us.
joining the Little Brain campaign.
Yeah.
You will be back. Pleasure meeting you.
Yeah, it was nice meeting you.
I know, and have such a great weekend.
All right.
Go
y'all
get
too.
some
Okay.
rest.
All right.
Yeah,
Bye.
go get some sleep. Bye. Thanks for hanging out with us today. Hopefully, you know you're not alone, and we're all in the trenches together.
We're always here, so reach out and let us know what's driving you nuts. We got you. Don't forget to subscribe, rate, and review the Little Brain campaign on YouTube, Spotify, and Apple Podcasts.
Questions or topics you want us to tackle? Hit us up on all of our socials at the Little Brain campaign. Keep trucking. You got this. We'll see you next week.
This podcast is for informational purposes only. Remember, no one size fits all. Always consult a professional for personalized advice.